Hello, this is Dr. Christopher Ferrigno. In this video, I'll discuss the joints of the lower extremity with particular attention paid to the hip and the knee. Let's start by taking a look at the superficial area of the gluteal region, which represents a transitional zone between the trunk and the lower limb. Specifically, it is the area posterior to the pelvis between the iliac crest and the gluteal fold. Have you ever wondered if there is an anatomical term for what we colloquially know as the butt crack? Yes, it's called the intergluteal cleft, seen here. It separates the left from the right gluteal region. A combination of fat and muscle separate the left and the right gluteal region. The muscles of this region are generally responsible for abducting or abducting, extending, and laterally rotating the femur at the hip joint. In regards to the osteology, the gluteal surface makes up the posterior portion of the ilium. If you look closely on a pelvis, you can see the posterior gluteal line for the attachment of the gluteus maximus muscle that will occupy the space between this line and the PSIS and the PIIS, or the posterior superior iliac spine and the posterior inferior iliac spine. The gluteus medius attaches between the anterior and posterior gluteal lines in that area. And the smallest of the gluteal muscles, the gluteus minimus, attaches between the inferior gluteal line and the anterior gluteal line. Be up in this area. These three gluteal muscles are layered in a pattern of crossing muscle fibers, one over the top of the other. The ASIS was introduced last time, but for the purposes of today, we'll see the tensor fasciae lata muscle attaching here. The ischial tuberosity is the site of attachment for the hamstring muscles of the posterior thigh. Let's review the attachment points for the muscles of the medial thigh. The trochanteric fossa is the site of attachment for the obturator externus muscle, a lateral rotator of the thigh. The lesser trochanter is the attachment for the iliopsoas. The pectineal line curves medially under the lesser trochanter and around the shaft of the femur to merge with the linea aspera for the distal attachment of the pectineus. The linea aspera is the site of attachment for the adductor muscles, that's the adductor muscles, the longus brevis and magnus. Let's see a few other structures. The greater trochanter is the site of attachment for the lateral rotators of the thigh and for two of the three gluteus muscles. The gluteal tuberosity is a roughened area lateral to the to the pectineal line and is the attachment site for the gluteus maximus muscle. The linea aspera, in addition to being the site of attachment for the adductor muscles, is a site of attachment for the short head of the biceps femoris muscle. The muscles of the gluteal region are divided into a superficial group containing 4 muscles and a deep group containing 5 muscles. In general, the superficial group of the gluteal muscles are responsible largely for abduction and extension of the thigh, and the deep group is largely responsible for external rotation of the thigh. That's also called lateral rotation, but realize these are broad generalizations. The gluteus maximus is a very large and strong muscle with a broad point of origin that encompasses the sacrum, the ilium, sacrotuberous ligaments, and the thoracolumbar fascia. As this very wide muscle obliquely crosses the hip joint, it attaches to the gluteal tuberosity and to the iliotibial tract. The size and orientation of the gluteus maximus makes it a very powerful extender of the thigh, especially when the thigh is moving out of the flexed position. Examples of this include walking up the stairs or rising from a seated position. Its oblique alignment also allows it to contribute to lateral rotation of the thigh and a little bit to abduction of the thigh. The inferior gluteal nerve and artery supply this muscle. We will see an image of this nerve on a later slide. The gluteus medius and gluteus minimus share an insertion and a nerve supply, and both are fan-shaped and have similar actions. In the picture on the left, the gluteus maximus has been removed to reveal the deeper musculature. Similarly, the picture on the right has further removed the gluteus medius to reveal the gluteus minimus. So this is the gluteus medius, and this is the gluteus minimus. The gluteus medius lies just deep to gluteus maximus and attaches onto about 2/3 of the gluteal surface of the ilium between the anterior and posterior gluteal lines. It's helpful to look at fiber direction to differentiate between maximus and medius as you get going with your dissections. The gluteus minimus lies deep to medius and attaches between the anterior and inferior gluteal lines on the posterior ilium, as we discussed before. Both muscles attach distally to the greater trochanter of the femur. It's worth pointing out that the anterior fibers of both attach anteriorly, or cross, I should say, anteriorly to the mechanical axis. As such, they will participate in medial rotation of the thigh. The posterior fibers of the larger medius will have small contributions to lateral rotation, especially when the limb is moving out of an already internally rotated position. That said, the primary functions of both the medius and the minimus are to: 1. Stabilize the pelvis of the planted limb when the opposite limb is non-weight bearing. For example, when you pick up your left foot off the ground, here we see this person picking up their left foot off the ground, your right gluteus medius and minimus act to stabilize the pelvis and prevent the left hip from dropping downward. The second primary action is abduction of the femur at the hip. So now if this foot was back down on the ground and this limb went outward, that would be the right gluteus medius and minimus taking that leg outward. The third action would be medial rotation of the thigh. This is particularly important when the limb is on the ground. Like we said before, the anterior fibers help to medially or internally rotate the thigh with respect to the femur. The right medius and maximus muscle help to turn the body to the same side or to the right when one is in single leg stance, which is effectively rotating the hip internally. Both are innervated again by the superior gluteal nerve and supplied by the superior gluteal artery. On both pictures, I'll circle right in this area, the approximate area where the superior gluteal artery comes out between the medius and the minimus and the muscle inferior to them, the piriformis muscle labeled with a P in this picture. Once again, during the unilateral stance, when one's leg is firmly planted on the ground and the other leg is swinging through, the gluteus medius and minimus are called upon to keep the pelvis level and stable. If there is injury to the superior gluteal nerve, the gluteus medius and minimus will be significantly weakened, if not paralyzed. Often this nerve is relatively intact, and the muscle can be otherwise inhibited by either hip joint pathology, such as arthritis, or some type of soft tissue injury, such as a labral tear of the hip joint. As a result of the decreased firing of the medius and minimus, they can no longer stabilize the pelvis, causing the side contralaterally to drop. Here we see that in the picture on the right, where the right gluteus medius is insufficient for some reason or another, and we have contralateral dropping of the left, or I should say contralateral dropping, so dropping of the left pelvis. As such, patients present with compensatory postures or movement patterns during the gait cycle. Also, upon musculoskeletal testing, they present with weak thigh abduction. Let's see this Trendelenburg gait in action and how patients can compensate for weakness of these muscles, either with an abductor lurch or a gluteus medius gait. Please take a minute to watch the video linked here of an individual with Trendelenburg, and after watching that video, try to answer these questions, or this question here, and come up with some solutions as to how that person can help herself during the walking process. The iliotibial tract is a thickened vertical band of fascia that extends from the iliac tubercle to Gerdy's tubercle on the lateral condyle of the knee. The IT band helps to stabilize the lateral knee when it's extended, as it has these fibers that extend outward to both the tibia and also to the patella. Two muscles merge into this band. We've previously seen the gluteus maximus connecting in with the band. Anteriorly, the tensor fasciae lata, or TFL, is a smaller muscle that is anchored at the ASIS and pulls on the IT band to assist in thigh abduction or abduction. Because the muscle comes off the pelvis close to the ASIS, it can also play a role in flexing of the hip, particularly when the hip is internally or medially rotated. The superior gluteal nerve travels through the posterior gluteal area to innervate the TFL after innervating the gluteus medius and minimus. With the gluteus maximus removed, we can also appreciate the deep group of gluteal muscles. These muscles are all going to attach posterior to the mechanical axis of the hip, making them all lateral or external rotators. They will also help stabilize the hip joint, working with the strong ligaments of the hip to steady the femoral head into the acetabulum. Again, appreciate that these muscles are located deep to the gluteus maximus muscle. In the table shown here, you'll notice the nerves are grayed out. That means they're not such an important focus because they're small and hard to find. The piriformis muscle is the superiormost muscle of this deep group. It originates from the anterior aspect of the sacrum, which is hard to appreciate here, but please realize this muscle is coming off the sacrum on the anterior surface, very close to the lateral edge. It emerges through an opening called the greater sciatic foramen, and I'll try to outline that here. Here's the greater sciatic foramen. The piriformis is an important landmark for the course of neurovascular structures. It receives innervation from the branches from L5, S1, and S2. Again, it laterally rotates and it plays a smaller role in abducting a femur, especially when it becomes a flexed femur. Then it can aid more in the abduction of that femur. There are two gemelli muscles. Gemelli means twins. They are thin muscles that sandwich the obturator internus muscle. So here we see the tendon of gemelli superior and then gemelli inferior with an obturator internus muscle traveling between the two. Careful inspection shows that the superior gemellus originates from the ischial spine, seen here, and the inferior gemellus from the ischial tuberosity, seen here. They both insert on the greater trochanter laterally. Here we see gemelli pasta, coined by the Italians because of the intertwined pasta strands. You will not be held responsible for that little fact. There's an extensive and robust ligamentous network in the posterior gluteal region. The two major ligaments include the sacrotuberous ligament and the sacrospinous ligament. The sacrotuberous ligament connects the sacrum to the ischial tuberosity. Recall that the gluteus maximus attaches to part of the sacrotuberous ligament. The sacrospinous ligament attaches the sacrum. It's a bit harder to see here. Sacrum over here, but then connects over to the spine of the ischium. These ligaments of the pelvis form openings called the greater and lesser sciatic foramen. The greater sciatic foramen, shaded in yellow, is a passageway for structures to enter and leave the pelvis. The piriformis emerges through the greater sciatic foramen, dividing it into an upper and lower half. Different structures exit above and below the piriformis in this greater sciatic foramen. Above the piriformis, we can see the superior gluteal vessels and the superior gluteal nerve. Inferiorly, we can see the inferior gluteal vessel and nerve, as well as the sciatic nerve. The pudendal nerve we see as well, but please don't worry about this now. We'll learn much more about it when we get into the pelvis. The internal pudendal vessels pass from the greater sciatic foramen under the piriformis and dive into the lesser sciatic foramen over the sacrospinous ligament. Again, we'll see these relationships when we get into the pelvis.
So here we see a little closer up the key nerves and artery to ID. Superior gluteal nerve and superior gluteal artery, which exit above the piriformis muscle, and then the inferior gluteal nerve and inferior gluteal artery, seen here, which exit below the piriformis muscle, along, of course, with the very large and very clinically important sciatic nerve, which also exits from below the piriformis muscle. It arises from the spinal levels of L4 through S3. So you could imagine what the herniation of which discs would cause such sciatic symptoms. If you guess the L4-L5 intervertebral disc, which is compressing the L4 nerve, or the L5-S1 intervertebral disc, which is compressing the L5 nerve, you would have been correct. Keeping these nervous structures in mind is important during injections into the gluteal region. In the safe area, you avoid the superior and inferior gluteal nerves and arteries, as well as the very large sciatic nerve. To locate the safe area, palpate for the ASIS and make a V with your fingers on the lateral hip. Right in the center of the V is that safe area. As the sciatic nerve exits underneath piriformis, it can become compressed. The term sciatica is a general term for when the nerve is irritated. The term piriformis syndrome occurs when the piriformis muscle directly compresses the nerve and causes symptoms. As a side, it is much more common for sciatica to be caused by a herniated disc compressing the nerve roots, like in a cauda equina syndrome from compression of the lower lumbar disc. Here are two tests to help with the diagnosis of sciatica. The Laseg test involves raising a straightened leg into the air and looking for buckling of the knee or arching of the back to avoid a painful response. The Braggers test builds on the Laseg's test. At the point of pain during the Laseg's test, the straight leg movement is back down ever so slightly, so it's brought down ever so slightly in the downward direction. Then the practitioner dorsiflexes the same ankle while maintaining a consistent straightened angle at the knee. A positive sign, again, is when a patient reports pain in the hamstring, in the back of the knee, or in the calf, or if they bend their knee or arch their back, in response seeking relief from the discomfort. The muscles of the posterior thigh are primarily hamstring muscles. 3 of the 4 muscles in the posterior aspect of the thigh are part of the hamstrings. The name hamstrings comes from the fact that it is common to hang hams, or pork thighs, with a hook around the tendons of these muscles. The 3 hamstring muscles are the semimembranosus, semitendinosus, and the long head of the biceps femoris. Together, all 3 muscles extend at the hip and flex at the knee. Again, they extend the femur at the hip and they flex the tibia at the knee. They all share attachments onto the ischial tuberosity and are all innervated by the tibial division of the sciatic nerve. The semitendinosus has a long cord-like tendon that attaches to the medial aspect of the tibia through what's called the pes anserinus. Pes anserinus is Latin, and it means the goose foot, thus the picture on the far right of the goose foot. The gracilis from the medial compartment and the sartorius from the anterior compartment also insert onto the goose foot along with the semitendinosus tendon. The semimembranosus is just deep to the semitendinosus. It has a shorter tendon and inserts more proximally onto the tibia than that of the pes anserinus. The long head of the biceps femoris is on the lateral half of the posterior thigh and inserts onto the head of the fibula. Hamstring muscles are very common in sport and can be quite debilitating and slow to heal. Interestingly, the different muscles of the hamstrings have different strain patterns, with the biceps femoris occurring most frequently and close to or at the myotendinous junction, proximally or distally, while the semimembranosus muscle occurs usually distally and the semitendinosus occurring proximally. While the arrow shows the myotendinous junction, oftentimes the injury occurs where the muscle attaches into the bone, specifically at these proximal injuries, and these can take quite a long time to heal. There is a small bursa that underlies the semitendinosus tendon. On occasion, this bursa can become inflamed and can herniate posteriorly, giving rise to a noticeable and palpable mass. Patients may think this is a tumor because it's not painful, but it can become quite large and noticeable, so large that it can interfere with normal flexion of the knee. Here we see 2 different Baker cysts. On the left, we see someone with bilateral primary Baker cyst. A primary cyst is rarely due to communication existing between the synovial joint of the knee and the bursa. It is localized to the medial tendon of the gastrocnemius or the semimembranosus. Importantly, this is usually idiopathic, self-limiting, and self-resolving. We typically see these in the younger population. Conversely, a secondary Baker cyst is broader, softer, and often indicative of underlying articular pathology. In this case, the cyst is the manifestation of inflammation finding the path of least resistance. These are very common in knee osteoarthritis, meniscal damage, and during the postoperative stages of knee surgery due to an increased swelling. The short head of the biceps femoris is a bit of a loner. It is not part of the hamstring group and will only flex the knee and participate in a little lateral rotation of the knee. Note, it does not extend the femur at the hip like the hamstring muscles. It attaches from the linea aspera proximally to the head of the fibula distally. It is innervated by the common fibular nerve, a nerve we'll talk much more about next time. To see the short head, one just needs to lift up the long head. The vascular supply for the posterior compartment of the leg is provided by perforating branches of the deep femoral artery. The popliteal fossa is a fat-filled diamond-shaped area posterior to the knee. The analog in the arm is the cubital fossa. The popliteal fossa is bound superiorly by the diverging muscles and tendons of the hamstrings, and inferiorly by the gastrocnemius and plantaris muscles. The roof is formed by skin and popliteal fascia, while the floor is formed by the joint capsule of the knee and the surfaces of the femur. The contents include the superficial structures found in the crural fascia, including the sural nerves, seen here in the far right panel, and the small saphenous vein, seen here. The contents deep to the crural fascia include the popliteal vessels, which are continuous with the femoral vessels inferior to the adductor hiatus, and the sciatic nerve divides into the common fibular and the tibial nerves. Please note that the sciatic nerve can divide much higher than the popliteal fossa. And the artist is showing here that the sciatic nerve up here has divided somewhere within the substance of the hamstring muscles into that common fibular and tibial nerve. This is the final slide in this lecture. Like the elbow, the knee has an extensive anastomosis around it. The 5 genicular branches of the popliteal artery supply the capsule and the ligaments of the knee joint. They are also responsible for providing collateral circulation to the leg during full flexion of the knee. There is no need to identify or be able to identify all these genicular arteries individually. Just understand their role conceptually and their importance in this anastomosis.